I will turn it over to you, Stephanie.
Thank you so much. And thank you very much to Veritech for inviting me to speak to you today. I'm really excited, and I hope you find this exciting. I guess that was a Freudian slip. So what I want to talk with you today is about how to actually quantify the relationship between our indoor environments and human health. Because ever since the pandemic, there's been a heightened emphasis on managing buildings to, in that case, decrease infections. But the challenge comes, in my opinion, in creating a database to move forward in a way that goes beyond opinions and non-verified strategies. So this is what I want to talk with you about in the next 50 minutes or so, and then I hope we have questions to go over. Let's see. So again, I'm very honored to be here in my life, which has gone on for quite some time now. I do a lot of things. I have a company called Building for Health. Veritech is actually our manufacturer's rep for our platform. I'm still involved at where I went to school at Harvard Med School. I work a lot with ASHRAE and now with the U.S. Green Building Council. And there you see me and my trusty companion who's right behind me. That's Luigi, my puggle. So you'll have access to this presentation, and I just put this slide here to hopefully focus your attention on what you will hopefully emerge with after this presentation. So really understanding how the indoor environment impacts our health, both from the perspective of infectious diseases and non-communicable diseases, as well as just supporting our overall health and functioning. I hope you will have a better understanding of how to design and operate buildings according to real-time visualization of indoor and outdoor air contaminants and thermal conditions. And in understanding the holistic picture, have a better understanding of how we can manage buildings both for occupant health and for net zero goals or decarbonization goals. And then lastly, and very importantly, I've learned is that we can't just talk about what is the quote unquote right thing to do. When you go to a building owner or manager, or if you're an architect to a customer, you have to be able to show a cost benefit. Again, in my experience, to really move the needle on your effort. So in the next, again, 40 minutes or so, these are the 5 areas that I'd like to go over. One, I was just going to tell you that how I, Stephanie, as a physician, came to be speaking to you. That's my awakening moment. I'd like to talk with you about health, the health impact of indoor air quality. And then thirdly, how do we actually bring together medicine and building sciences, again, in a way that's quantifiable? And then how do we understand who the stakeholders are in buildings? How do we speak to these stakeholders in such a way that this message is meaningful? And then I wish I were there in person so we could have a roundtable discussion on next steps, but hopefully we can do that through the discussion. So this was the beginning of my journey to you. So this is actually me before my hair turned gray. This is when I was in medical school. I was in my, I guess, mid-20s. I went to Papua New Guinea for 4 months to work in some clinics and in some very rural areas. I had a blast, as you can see. I never got very good at climbing coconut trees, but I tried. That was the first injection I ever gave a patient. We were both scared, I think. And when I was in New Guinea, I was stationed primarily at the Wewak General Hospital. And this is what the indoor conditions look like. You can see the men's tuberculosis ward on the left. Beds were close together. Concrete floor was dirty, had cracks in it. There's pretty good ventilation, definitely operable windows. On the right, you see me in the operating room with flip-flops on my feet, which is what everyone wore. Often there were no surgical gloves available. So I thought, oh my gosh, these poor patients are going to get worse infections, or they're going to get new infections. and they're not going to go home, or they're going to die, or they're going to have prolonged hospitalizations. But I was really surprised to find out and to experience that that was not the case. So despite this kind of dismal looking surface hygiene, patients did pretty well. So then I went back to Boston, to the Harvard teaching hospitals that look like this. You know, they're beautiful, beautifully designed. The surfaces look very clean, private baths, single rooms. And I learned more and more about the epidemic of infections that people get from their hospital experience. So healthcare associated infections. And these are real people, as you can see with the images. So I was really concerned about this. We don't go into the hospital to get sick or die. We go hopefully into the hospital to get better. So I talked with one of my professors, my mentor, Dr. Folkman. And this is a prod for me to be an advocate for finding a mentor or being a mentor, because I think mentors are invaluable. But Dr. Folkman told me, he said, never, ever underestimate the role of the environment. And he was a brilliant man, so I took him quite seriously, although it took me until my 40s before I realized that I didn't know much about buildings or about mechanical systems. So I went back to school, got my master's in architecture, and designed hospitals. And that was really the when I transitioned into what I'm doing now. So what do we know about our health and indoor air quality? So before we get into that, into a couple studies, I would just want to show you this video that will give you a pretty good visualization of what is going on around us that doesn't meet the eye. So as I'm in my office in Vermont talking, and you're all in your space breathing, hopefully, we exhale droplets about 100 microns in diameter. And they carry the normal viruses, bacteria that are in our airways. Doesn't mean we're sick. That's normal. This architect or engineer is working away. She's leaving her skin particles and all of the organisms that live on our skin. She's leaving them on the surface. You can see they're coming off of her body. As she exhales, particles come from her nose. It's not like she's dripping or anything. It's just breathing. Her GI tract is illuminated because we have a lot of particles and organisms in our digestive system. You can also see from this video, which is based on tools like PCR analysis, you can see that there's a lot of communication between surfaces and the air. And that depends on the degree of turbulence, the humidity, and some air factors. But we live in a 3D world, so surfaces communicate with the air and vice versa. And then depending on how sealed your buildings are, there'll be more or less communication between the indoor particles and organisms and the outdoor environment. So I think that's a really, I love that video because I think it gives us a very good understanding that there's a lot going on. So by using some new tools that have existed in medicine probably for the last 20 years, but we have now moved into building assessment with these similar tools. And everybody on this call is very familiar with the initials PCR. We use PCR tests for COVID-19, and that's a genetic analysis tool that we can now bring into the building and have a better understanding of what organisms are around us. We've learned a lot. For one thing, we've learned that our old attitude about bacteria and viruses is really not accurate. All bacteria and all viruses and all fungal organisms are not bad. They're not germs. As a matter of fact, 95% of them are actually good for us, and we couldn't live without them. So we need to move beyond this attitude. It's a little bit harder to do after a pandemic, but not all microbes are going to hurt us. Many are going to help us. So when we think about surface disinfection, surface hygiene, indoor air management, indoor air cleaning, the use of ultraviolet lights, etc., those tools are very, very beneficial in many situations, especially if we're needing to disinfect a high-touch surface, or if we're in a hospital where people have maybe a suppressed immune system. But we need to get away from this idea that we want to eradicate all the organisms, because what we generally do are eradicate the ones that are actually good for us. So in fact, one way you can improve your environment, believe it or not, is to get a dog, unless you're allergic to dogs. Dogs have a very healthy microbiome. Children and people who live with dogs tend to have, again, unless you're allergic to some component of them, tend to have a more robust immune system and fewer infections. And kids who grow up around animals have a much lower incidence of asthma and ear infections, for example. So dogs are great. Cats are sort of a different story, but we won't get into that right now. So these are my dogs. So I think I have a very good microbiome, very good microbial environment. So let's step back for a second and let's think about human health in the indoor environment. And whoops, from the pandemic, we're used to thinking about, we were mask wearing and ventilation and social distancing to decrease our exposure to infectious aerosols or infectious particles. But the part that we tend to forget about, which is equally important and perhaps even more important, is the impact of the indoor environment on our bodies, on our immunity, on our metabolism, on our ability to think. So we need to manage buildings not only to decrease dangerous exposures, but to support our underlying physiological mechanisms. So that's what I want to talk with you about next. So what do we know about, what are some medical studies that relate the indoor environment to our immune system, for example? So this was a study that came out in 2019, where a researcher at Yale University was asking, why is it we get the flu in the winter, in temperate climates? So Dr. Iwasaki looked at all sorts of variables: crowding, vitamin D exposure, outdoor temperature, outdoor humidity, indoor conditions. And of all those variables, she narrowed it down to low indoor relative humidity was a very powerful factor in flu seasons. This is prior to the pandemic. So then Dr. Iwasaki used genetically engineered mice to ask, what is low relative humidity doing to our immunity? And it was really fascinating, and it's very powerful as well. So she found that not only when the air is dry are there more airborne particles, which could be viruses. She found that at 20% relative humidity, the natural immune barriers in your upper airways are impaired. The mucus in your sinuses and throat becomes more viscous. Those little protective hairs can't work as well to protect your lungs. When the air is dry, our bodies don't produce protective proteins like interferon. So if you stop and think about that, how does dry air impair the production of protective proteins? I mean, it's an incredible association. And without these protective proteins and without some of the stimulants for our immune system, we don't have the same protection that we do if we have a moderate amount of humidity in the air. So this is just one example of sort of a surprise, in my opinion, a surprise about the relationship between indoor air and our health. And it goes beyond humidity. Any inhaled component, ozone, particulate matter, NO2, SO2, can cause inflammation of our airways. And the inflammation will occur either in your upper airways or in your lower airways, depending on what the compound is. But if you're exposed to viruses or if you're exposed to bacteria in the air, the last thing you want is to have your airways inflamed, because then you're even more vulnerable to getting sick. So I was working with relative humidity and the harm from low relative humidity for a long time. And I wanted to branch out and really understand some of the other components that are indoors. So these are just a couple studies. And then I'm going to talk about how we can actually, in real time, manage our buildings to optimize health. This slide shows how even low levels of ozone that either comes in from the outdoor tropospheric level, or ozone that our printers might produce, or like recharging batteries produce ozone. And even low levels are really inflammatory to our airways, and you might not even perceive it. But you can see in the top part here how this is a normal, healthy airway with no ozone in the indoor environment. And in the bottom part, you see how with even low levels of ozone, 20 parts per billion, you begin to see inflammatory cells infiltrating. You see the lining of the airways get sort of ragged and disorganized. Not good. This is a example of the same layer of your respiratory system that shows that if you have ozone and if you have NO2 from the outdoor, from say outdoor pollution, and you have low relative humidity, you're kind of in big trouble. Your airways go from looking nice and smooth like this to looking much more ragged and vulnerable to harm. Your brain, I think you're getting the picture. None of this is good for you. These are MRIs of normal, healthy young adults who have inhaled, who have been exposed to PM 2.5. These particles settle in different parts of your brain, have different consequences. None of it's what you would ask for. So what are the consequences? So just for our brain, on the left, a study at MIT showed that when PM was increased by 10 micrograms per cubic meter, chess players made 26% more mistakes. I mean, I'm not a very good chess player, so that probably wouldn't matter for me, but it is an example of how poor indoor air quality impairs your thinking. If you're an umpire in a high stakes baseball game, you know, you don't want to be in poor air quality environments. Similarly, if you're taking a test, a standardized test, your chance of doing significantly worse is increased by 8% when you have higher PM 2.5. And you'll have all these references in the bibliography when you get this presentation. So anyway, it's a powerful influence. So how do we bring, I mean, these studies are interesting or they're scary, but how do we actually make them useful for building management? To do that, we need to unite the building science, building design, operations, commissioning, with data from medicine. Because by and large, I won't say everyone has separate professional silos. I mean, I don't, for example, Dan and Kelly don't. Hopefully people listening to this call are beginning to understand the health implications of their work. But we need to have data to unite these two professional silos. And in my opinion, make occupant health the key to our building management strategies. How do we do that? To do that, we need data. We need to expand our database from the sort of more traditional engineering or air quality metrics, such as particles or CO2, temperature, humidity. In hospitals, we talk a lot about room air changes, pressurization. But in addition to those metrics that are important, we need to bring in data that shows how indoor air quality affects our bodies. How do we quantify indoor air quality's impact on our immune system, on our inflammation, thinking, on our metabolism? How do we quantify indoor air quality and microbes, the presence of microbes in our bodies, the presence of microbes in our buildings? So these are the data sets that I believe we need to really correlate with health outcomes. Sorry, Dan, am I going too fast? I can't hear you. I can just see your mouth moving. I'll take that as a no.
I don't think you're going too fast.
Okay. So if you think about studies, if you think about how to understand toxicology, we need to think about more than just what we're exposed to. We have to think about how those contaminants actually get into our bodies. And once they do get into our cells or our tissues, do they cause disease? Or do they just make us uncomfortable? So we need data across a continuum from exposure to health outcomes. So now I'm going to talk to you about some of my work in the last 4 or 5 years, which has been to create an indoor air quality health standard to quantify the impact of indoor environments and our bodies across the board: respiratory, cardiovascular, immunity, thinking, inflammation. Sorry. So how do we do that? How have I been doing that? And this is the platform that Dan and Veritech are manufacturer rep for. So what we do, we measure the indoor air constituents that impact our health. We analyze them through a health-based algorithm. It's up in the cloud. If you're monitoring your building, we communicate the results back to you, and then we offer remediation recommendations that are the most effective and efficient. So what are these 4 steps? First thing to do is to figure out, okay, which indoor contaminants or which airborne contaminants have the most impact on your health. Because we don't want to measure everything under the sun, but we want to measure everything that's really important. So the first step is to identify those constituents. The second step, and this is how what we're doing is different from, for example, the EPA. So we look very holistically at all of the metrics you see listed on the left. And we quantify the health impact, not only of those things individually, but how they combine and impact your body. So for example, if you have particles in the air and low levels of ozone and low humidity, you're going to have a much higher impact in a negative way than if you just had PM by itself. So it's really important, in my opinion, to look at the combined impact of these things. So then we quantify the impact and we report to the customer or to the building owner or the manager or the occupant a single score. So if you're busy and you don't really want to have a lot of data dumped onto your to-do list, we just give you a single score. And then if you want to, you can go back and understand what makes up that score. Again, sometimes people say, well, this sounds great, but how do you know that it really means anything? So how do we know that you're not just sort of making this up? So I put this slide in here to show you some of the medical foundation, some of the cell biology foundation that underlies our strategy, which we've verified with folks at the EPA, MIT, Harvard Med School, and beyond. But anyway, so this slide tells you some of the biological changes that go into our quantification. Where do you get these studies from? Where do you get the information from? And this is one of the things that's really exciting for me, is that I'm able to analyze data from across the board, all the different areas that I'm fascinated by. This is, you put all your findings and your conclusions into an algorithm, and this is what you have to work with, what we have to work with, and then we report back to you. So Dan is familiar with this. Veritech is monitoring their offices, as well as another project that's really exciting. So this is a dashboard. Again, you can go into it and do data analytics at a very detailed level if you want to. So what have we found? So now I'm going to show you just a couple of studies, a couple of case studies that reveal the relationship between the indoor environment and human health. This study is actually from before we had developed that platform, but it's taking the same approach. So this study is from 2014. This was a brand new hospital in Chicago. And some microbiologists were wondering how the microbial population changes in a hospital building from before it was ever occupied, so after construction, but before occupation, up to a year after patients and staff were in the hospital. So the microbiologists were looking at the patient room environment, monitoring all the things you see listed there, and correlating patient rooms and adjacent nursing staff, nursing stations with the microbes. So they're doing this on 2 different floors to begin to control for the myriad of reasons people come into the hospital. So one floor was a cancer treatment floor, the other floor was a general med surge area. So I found out about this study that was going on for about a little over a year. And I said, I'd love to look at patient outcomes in those rooms. And, thankfully, for me anyway, thankfully, the head of the project was not a physician, was not particularly up on HIPAA and IRB regulations, and just sent me a massive database of patient outcomes. This was before the hospital lawyers found out what was going on. But anyway, so we correlated environmental data points with patient outcomes. We found in this study that the most powerful driver of infections, or the most powerful correlation with higher infections, was lower relative humidity in the patient room. I was astounded by this. This was before the Yale study. This was before a lot of data that's come out about the harm from low relative humidity, primarily. High relative humidity can be uncomfortable. High meaning over 60%. It can lead to conditions that contribute to mold growth if you have interstitial condensation in a building. But there's a very beneficial zone, 40 to 60%, that's very good for the human being, and it decreases the number of pathogens in the air. Again, that's a whole topic in itself. I was skeptical because I had no idea at the time about this problem with low relative humidity. So this was another study that we did over 4 years, looking at the same parameters. And once again, low relative humidity, less than 40%, was associated with higher infection rates, bacterial, viral, in all systems except for urinary tract, which was more related to hygiene and mobility. But again, once again, we found that low relative humidity was associated with higher infection rates. So that was really identified relative humidity. This is a more recent study done by my colleague, Damon Greeley, where they monitored the 8 operating rooms in I think it was Indiana University. So they monitored all the different environmental factors that we were talking about in an earlier slide. And the hospital only used operating rooms which were in the green. So this is over a period of 3 months. So if you were in the red or in the yellow, no surgical procedures were done in those spaces. And the metric that was being analyzed was surgical site infections. So what did they find after 3 months? They found that when only the good spaces were used, when only the green spaces were used, they had an 87% reduction in surgical site infections, which saved the hospital a lot of money. So if you're beginning to think, oh my gosh, I don't live in a hospital, I don't design hospitals, I don't manage hospitals, I just want to point out to you that the data that we've learned from the healthcare environment actually applies to all of us. It's just that hospitals are a great place to do this sort of study because we can gather so much data on the occupant, meaning the patient. But the trends that we've identified in hospitals also apply to offices, schools, homes. So even though you're not having, abdominal surgery in your living room every night, the trends in hospital environments that affect your health also tend to affect our health in all indoor spaces. Okay, so what about energy? All this talk about health is important, but really we're focused a lot on energy conservation and decarbonization. So are we just going to create a worse energy problem if we manage buildings for health? And the answer is no, we don't have to. There'll be some situations where there may be a trade-off, but we can manage both of these. We can manage both the indoor environment and optimize outdoor air quality. So how do you do that? So what we found is that when you monitor holistically, so what I mean by that is if you monitor indoor air quality and outdoor air quality, ideally right near your intakes or close to your building. If you don't have a monitor outdoors, hopefully you'll have publicly available data that's close by. But we recommend monitoring your building on site. And interestingly, but not too surprisingly, if you know what's going on outdoors, you can decide what is the best ventilation or filtration strategy. And Dan can talk much more intelligently than I can about how you actually manage mechanical systems. But what I can tell you is that if you know the constituents outdoors, you can decide the best strategy for indoor air management. And part of the reason this is important, part of the reason it's important to know the outdoor air quality is that we found that, for example, if you have a high ozone day outdoors, and say you have VOCs off-gassing indoors, that combination is going to create more particles, which is not a good thing. So you can choose the best strategy to optimize your indoor air quality in the most efficient way. So here's a study we did in Wisconsin, and it just shows graphing on the y-axis your health score. So 100 is good, 0 is bad. And you can see here, if you monitor your indoor and outdoor air quality, you can identify times that you don't want to ventilate without filtration, or you don't want to just increase ventilation without any air treatment. And again, that's really more Dan's forte than mine. But back to this study, back to this operating room study, this hospital also found that they were able to turn down room air change rates in their operating rooms and save quite a bit of energy. The price varied depending on what the source of the energy was. But by having that visualization of the indoor air quality in the operating rooms, they were able to decrease some of the energy costly mechanical systems. So this again is an example of how holistic monitoring can both improve your indoor air quality for health and help you save money from energy. So how do we take the business case beyond energy? You know, if you're a monkey or an animal, as sad as that is, in a research facility, or if you're an astronaut in the International Space Station, or if you're a famous painting or piano, you're going to be in a great environment because there's a clear price tag on your head. But how do we create that same price tag for all of us? We're not a research animal or an astronaut or a famous painting. So I've been thinking a lot about this and working on this, on understanding the stakeholder in different building types. And this is sort of an overly complicated slide. But what I'm trying to do here is to understand from the perspective of different building verticals. What is the building used for? What is the energy consumption? Who's involved in managing that building? And what costs matter to that particular type of building? So to make that a little bit clearer, but still a very busy slide, this is an example of creating health performance indicators in a senior living community. So senior living communities are a type of building where the health of the occupant is very much aligned with the business, with the cost, with the profitability of that community. So I show you this so that if you embrace the idea of managing buildings to support health, and you want to create a cost benefit analysis, think about the challenges that are that building owner or manager is confronted with, and how can you benchmark, reduce costs from pain points? How can you improve the market share of that building by showing that you have a improved indoor air quality strategy? You know, again, I don't know everyone who's on this call and what sort of quote unquote smart building strategies you're using, but bringing the health piece into your smart building management is a huge value added, in my opinion. So where do we go from here? Oh my gosh, I got through that pretty fast. So again, I wish, and I hope you have some questions or comments or discussion points, because moving forward is something we need to do together, meaning medical professionals like myself and engineers, architects, those of you in construction or any aspect of the building industry. I think we need to embrace this change. ASHRAE is definitely slowly but surely moving in what I think is the right direction. We need, in my opinion, to move from sort of static data on building management, air change rates, commissioning, and move to a real-time monitoring of the components that are known to impact our health. I think we need to move beyond giving a nod to the occupants with the word comfort. Comfort is important, and subjective experience is important, but it's not the whole story. ASHRAE is moving in this direction. ASHRAE 241, which is a standard to address indoor air management during an infectious disease outbreak, was developed in a record amount of time. There's also a guideline 44 from ASHRAE that guides building management if there's an outdoor air pollutant event, such as a wildfire. USGBC has just, we've actually today, we finally have our released LEED V5 version 5 for new buildings, which integrates energy conservation and indoor air quality management for health. They're legislative initiatives that you probably are aware of around decarbonization. And actually, just before this call, and just before this meeting, I was working with the GSA, General Services Administration, because I'm part of the team there where we're developing high performance building standards. And I show you this at the bottom. This is the timeline that we're working with. So we just have begun to go over our, well, it's not quite the final report, but there are about, I want to say 80 folks, maybe 60, who and were involved in identifying indoor constituents that are important for health. We're working on relating those constituents and management of those constituents with building HVAC systems. So anyway, you can see we are right about here between the draft report and what we will be turning out, hopefully by ASHRAE, which is June 24th. So this is a really, really active area of change and research, and I hope you all are working on this. I know Veritech is. Veritech is like one of my, Veritech inspires me immensely. They're very forward thinking. And anything I can do to help or answer questions, I'd love to do that. One thing I do feel strongly about is that perfect is the enemy of good. We shouldn't get totally tangled up on, you know, what metrics or what thresholds for metrics. We need to move forward the best we can at this point in time. Because exposure to indoor constituents is only half of the problem, half of the story. The other component is how indoor air quality affects our bodies and makes us more or less vulnerable to disease. I personally believe that we should be managing indoor environments based on concentrations, not only on ventilation rates. We can no longer assume that outdoor air is fresh air. So I think monitoring concentrations indoors and outdoors is key. Similarly, comfort is not a great indicator of constituents of indoor air quality beyond thermal metrics. CO2, carbon dioxide, is an okay indicator of occupancy, but there are other components, VOCs, ozone, that CO2 is not a good marker for. So again, CO2 is an important one, but it's not the only important metric to follow. So in conclusion, I believe that managing our buildings for our health is one of the most underutilized and potentially beneficial tools. As a physician, I can honestly say we've kind of made a mess of public health. You know, in the United States, our healthcare system is way too expensive. We've created an epidemic of antibiotic resistance. There are a myriad of problems when you approach health from the perspective of the business of sickness, which is what US medicine is about. So I think that those of you who are managing buildings, designing buildings, operating buildings, the future of our species is in your hands to begin to employ some of these preventive measures to support our health. I think it's really, really, really important. And then my last slide is, if you don't measure it, you can't manage it. So this is me. I do a lot of skydiving. I have, I don't know, 1,400 jumps, I think now. And this was one day when my husband happened to come to the drop zone with a camera, unfortunately. And my altimeter was off by about 200 feet. So when I came into my final to land, I came in way too fast, and I did this very humiliating face plant because I wasn't able to measure my altitude. If you can't measure it, don't measure it, it's hard to manage. Versus the day I had a new altimeter that was calibrated, and it was fun, I was relaxed, and no crashing and burning. So that's my if you don't measure it, it's hard to manage slide. So thank you. Thank you very much, Dan. I'm going to stop sharing, and Kelly, and then maybe we can have questions.
We do have a question. So just as a reminder, if you do have any questions, you can pop them in the chat. Also, feel free to unmute yourself and we can make this a conversation as well. So the question, are some of the preventative measures being implemented to schools and daycares due to rise of kids and students getting sick more often?
You know, schools are a very logical place to bring this strategy, and we are managing some schools, more higher universities. And there was a lot of money that was actually allocated to increase the HVAC systems of schools, to improve the indoor environment during and after the pandemic. But unfortunately, a lot of those funds seem to have gone to other things that were perceived as more immediately necessary, which I understand. So schools are a logical place, but they're not, I don't think this approach has been integrated into schools as much as I wish it had been. Daycares, sort of the same issue. In my experience, the most profitable, the places gain the most traction are senior living communities and commercial office buildings. But any thoughts that you have, any of you people who are on this webinar, any ideas you have about moving forward with this or penetrating the market more broadly would be absolutely wonderful to hear.
We have another question that popped in. What kind of tools are there for buildings or that popped in? There are two questions popped in. I started reading them together. What IAQ metrics should be monitored? What instruments used to measure these metrics? And what is maintenance and calibration cost of said instruments?
Oh my gosh, great, amazing questions. So the sensors that we use, we meaning my company, are actually made by TSI. They measure 11 different constituents. temperature, humidity, carbon dioxide, carbon monoxide, TVOCs. We can get back to that. If you want NO2, SO2, ozone, and particulate sizes and counts. In some environments, I think you can do without SO2 unless you have either an industry or you're near highway. I think SO2 is the one that I negotiate with on, but I think the other ones are really important to monitor. The sensors that we use cost about $800, which is sometimes seems like a lot, but that's how much we have to pay for them. I hope that, yeah.
And if anybody has any
Answers it.
follow-up questions, feel free to come off mute or type in the chat again. Another question, what kind of tools are there for buildings or mainly living areas that can measure humidity, and how can they be adjusted via HVAC to within the 40 to 60% range?
So there are a lot of hygrometers that are available. I have this little one here that I use in my office. This is our monitor that I use. I have a bunch of monitors in my office, but just to measure humidity by itself, humidity and temperature, you can get a little hygrometer. I think they cost anywhere from $4 on up, where you can make if you have kids or somebody who's interested in understanding what relative humidity is, you can make a wet bulb, dry bulb hygrometer yourself and put a fan on it and then convert the sensible and the latent temperatures to relative humidity. That's a great exercise. But probably the easiest and cheapest thing to do is to go to your hardware store or online and buy a hygrometer.
Also, I mean, talking about how to get it adjusted by the HVAC system, I don't know, like Amr, I know you're on, in our controls department about, integrating B4H with controls to be able to adjust the system as well to stay within those parameters. I don't know if Amr or any of our controls guys have any input to that.
That's a forward-thinking person right there, because that is I wake up in the middle of the night hoping and praying that we get to that automated feedback loop sooner rather than later.
And Dan, I saw you come off mute too. I don't know if you had any. Were you thinking the same thing?
Yes.
Yeah, I don't know.
It's around the corner. I think hopefully, again, perhaps working with Veritech, we're going to cross that bridge.
Mm-hmm.
You get into cybersecurity questions and issues depending on your type. Again, I was just on a call with GSA and they were just like, no, you're not going to control our HVAC unless you figure out these security steps.
Right. Yeah. The linking to the cloud, kind of freaks some people out. Oh, we have more questions coming in. A lot of good questions. Does measuring PM 1.0 particles provide
Credible. Sorry, misspelled that.
a credible?
Is that you, Dan?
That's me.
Dan.
Does it provide a credible metric for evaluating aerosolized potential pathogenic material concentrations in a space?
So Dan, again, really good question. Viruses are small, at 0.4 microns. We don't exhale naked viruses. Mm-hmm. So if you try to say, well, 1.0 is way too big for a viral particle, if you think about what you actually exhale, it's an aerosol. So no, measuring 1.0 particles is not an exact science to correlate with viral exposure, but it's a really good start for a number of reasons. One, for the reason I already said, bioaerosols agglomerate viral particles. Number two, higher particle levels particles actually carry viruses. In addition to bioaerosols being particles, mineral particles and other particles of other ingredients actually carry bacteria and viruses. some really interesting studies out of Italy during the pandemic correlating particle levels with infection rates. So it's not a perfect picture of viral exposure, but it's a very good correlation.
Thank you.
Right, considering a lot of healthcare facilities such as acute care buildings or long-term care buildings require substantial coordination between clinical and engineers to put the sensors in, what would be a lesson learned you can share to make the coordination smoother?
Good question. Start with a space such as an operating room, where for reasons having to do with clinician comfort primarily, surgical comfort, the spaces are being monitored. So, surgeons like to have operating rooms cool because they've got multiple layers of sterile, scrubs on or sterile robes. So some surgeons want the temperature to go down to 66 degrees during surgery, which increases the humidity. So operating rooms tend to be monitored already. So I think one of the ways to get into a healthcare facility is to address something other than infection rates in patients, because hospitals are loath to talk about metrics that they could be penalized for. Medicare, CMS penalizes hospital for high infection rates, so they don't really want to talk about that. But if you go into a hospital and you talk about clinician comfort, or if you talk about clinical staff illnesses and ways to reduce absenteeism, you'll have a much better, in my experience, a much better chance of a hospital actually embracing this idea. Hospitals are tough to get into. Again, that's been my experience.
How can you look at an older building which doesn't have much flexibility in changing the HVAC? Does monitoring help in that case?
It does, because if you think about some old buildings, like even say vernacular buildings to go perhaps further back in time, buildings can be leaky, they can have a lot of exposed wood or concrete or stone, and they often have really good indoor air quality. So a new building or a building that has a lot of synthetic materials is not necessarily going to have the best indoor environment. So, don't judge a building by its cover. And yes, monitoring will give you a very good view of what your starting point is. And then if you do make that implementation, whether it's opening a window or humidifying or dehumidifying, you can see if you're achieving the goal that you hoped for. So don't be discouraged if you don't have a big fancy building. Sorry.
Don't let the age of the building fool you.
No, don't.
Are you familiar with light level and spectrum impacts, including UV on health?
Yes. Yes. And yeah, I am.
Okay.
UV wavelengths have a fairly broad spectrum and different effects. Do you have a?
Yeah, Greg, if there's a specific question, if you want to pop that in the chat, go for it. That was the question. So yeah, if you want to get more specific.
I see one from
here we go.
Billy.
Yep, with energy conservation, are we leading into solar or wind turbines in respect to HVAC systems? Oh,
Gosh,
Dan,
somebody else can answer that a lot better than I can.
Potentially, I think what we're going to start seeing more, however, are smart grid systems, and how can areas of a municipality share and distribute energy depending on building demand and load and energy required, and more effective distribution of power usage to buildings where that power is needed is probably more immediate in addressing the needs of any specific building within a given area or whatever. I think that's more discussed today than looking at renewables as local resources to a building. But in this day and age, anything could happen tomorrow. So that would be my guess.
If we read about it, we'll put it in our newsletter for you.
That's right.
All right, so we have reached the end of the questions. I don't see any more coming in. Dan, do you have anything else? Any questions?
I certainly don't, but I want to thank Stephanie Taylor for working with us and bringing your expertise into our Southwest market. We appreciate you and the wisdom you bring to the table, and we thank all of our guests today for joining us for this presentation, and look forward to seeing you again in the near future.
Yes, and I will follow
I
up with
wanna
an
thank
email
before-
with
Kelly, wait.
PDHs. Oh, yep.
I want to thank you and Dan, and I have to say, I've been doing this work now for years, and Veritech is one of the most inspirational companies that I have worked with. I really admire you guys for moving ahead with addressing human health in the indoor environment. You're just doing a fantastic job.
Thank you.
Thank you,
Stephanie.
Stephanie.
We enjoy working with you as well.
It's a mutual,
Yes.
mutual relationship for sure.
All right,
Thanks.
so I will be sending out the PDHs. Brian, you have not received, yes, you have. Brian said he didn't receive the last PDH, but I will double check on that, Brian, and make sure. I will get an email out with a link to the PDHs, a link to our website with the recording and with the PowerPoint presentation as well. We'll do it in PDF format. And as always, if you have any more questions, you can always reach out to me or Dan or to your Veritech salesperson. And again, thank you so much, Stephanie.
Thank you.
Thank you.
And thank you,
Stephanie.
everybody, for
Thank
joining
all of
us.
you.
Thanks, everyone. Take care.